Hi, everybody. Welcome. We are going to give attendees just about 2 minutes to join the event, and then we'll get started. Welcome, everybody, and thanks so much for joining us on what is, for many of you, a Friday afternoon. We know that folks will continue to trickle in as the event gets started, and I'm happy to say that we had just under 700 registrants, so we're pleased to have such a broad reach. If we can go to the next slide, please. This event will be interpreted into both French and Spanish. In order to access the interpretation language channels, you can open up the toolbar on your Zoom screen and look for interpretation. You'll see the globe icon shown on the screen, and then select the language you'd like to listen in. Next slide, please. Before we begin, I do want to mention a quick number of logistics items. The first is that during our Q&A session, we'll pull questions from the Q&A box rather than the chat. So please feel free to ask questions in Q&A at any time. We also ask that you remain muted throughout the event. And then finally, this event is being recorded, and the recording and slides will be sent to registrants following the event. Next slide, please. So we have a fairly quick event today covering broad ground on contraceptive access. The event will begin with opening remarks from Dr. Sheila Macharia, and then we will move into an exploration of health systems enablers from Wale from Market Access Africa, and then two different analyses on understanding demand for products, and then ending our presentations with a presentation on advocacy and policy setting for contraceptive access before launching into Q&A. Next slide. So before we begin our first session, it's my pleasure to introduce our moderator for the event today. Dr. Sheila Macharia currently serves as the first managing director for the FP 2030 East and Southern Africa Hub. Dr. Macharia is a renowned global health advocate and policy expert with over 20 years of experience building deep regional and global networks of public health and development stakeholders. At FP 2030, she oversees a multidisciplinary team that supports commitment makers and advocates for increased investment in family planning. Dr. Macharia, over to you for brief opening remarks.
Good morning, good afternoon, good evening, everybody. We welcome you to this learning event and are particularly happy that you would be able to join us as we look at a topic that is very central in our efforts as global partners. We are all agreed that family planning needs to remain at the center of development efforts, at the center of gender equality, and that countries should prioritize availing information and services for family planning. In order to do that, one of the health systems that they pay attention to is a supply chain to ensure contraceptive commodity security. And a critical part of that is ensuring that there is access to a wide variety of contraceptives to meet the various needs of women. We are therefore happy that this afternoon, our three speakers will be providing a picture of what the introduction processes of the next generation of contraceptive products could be. This is important because we are living in a time when we have a huge population of adolescents who are rapidly getting into the era of reproductive health. And therefore, we need to be nimble and we need to be prepared. From the speakers, we will hear about global decision-making processes, country-level advocacy, and local health systems. Our three speakers are Clancy Braxton, Wanjiko Manguyu, and Olawale Ajose. This afternoon, we will begin by hearing from Olawale Ajose. He is the managing partner at Market Access Africa. Within this role, he oversees the expansion of the firm's capabilities in key strategic areas, and more broadly ensures that the firm continues to meet the changing needs of its clients. Olawale is also the co-founder of the AHC Barging, a logistic company in Lagos. He holds a bachelor's degree in cell biology and genetics from the University of Lagos and a Master of Public Health from the University of Warwick. He will be speaking to us about the health system enablers for contraceptive access. And without further ado, I welcome you, Olawale, to give us your presentation.
Thank you so much, Sheila. Can you hear me clearly?
Yes, we can.
Okay, thank you for the introduction. Yes, still at Market Access, but actually AHC Barging was many years ago. Failed woefully at that business. That's a story for another day. But let me start by saying thanks to all of you for having me here today and for the opportunity to share our experience working on strategies for contraceptives and other health products. As a firm, we work almost exclusively in Africa, and so some of the things I'll be sharing today is based on our experience working on the continent. But I'm sure it would have similarities across other continents as well. Next slide. So there are three, I would say, undisputable facts that I often like to start my presentations with. And I do this as a way of reminding the audience that what we're doing is complex and it requires out-of-the-box thinking for us to succeed. The first is that health systems are not uniform, and we all know this. But in global health, what we often do is to paint all countries with the same brush and take almost a uniform approach to product introduction. But the fact is that what works in Nigeria may not work in Kenya, and even within Nigeria, what works in, say, Lagos may not work in Kano, because people are different, because their experiences are different, because health-seeking behavior is different. The politics is also very different, and so on. And so acknowledging this from the outset as you design your program and tailoring your strategy to that acknowledgement is very critical. The second fact is about the stakeholder ecosystem. There's a world out there that does not operate within the typical global health circles that we operate. And it's incumbent on all of us in this room to go out and seek out organizations that do not work in this space if we want to be successful in access. There's a role for organizations like ours. There's a role for organizations like CHIs of this world and PSIs of this world and so on. And we're pretty good at what we do, but we need to also recognize that there are organizations out there who are better at many things. And these organizations wouldn't necessarily be on this webinar, for example. So we need to go out and expand that circle beyond what we're used to in global health. And The third point that I want to just start with is it has to do with the fiscal space. We're all fighting for the same pot, and decisions on what to pay for at the government level and also at an individual level ultimately comes down to the relative importance or priority I place on a product or on a contraceptive product over something else. And the hard truth is that contraceptives may not come before many other things. And so we're really engaging in a space where the fiscal situation is pretty dire and we need to think outside the box. So with that said, let me actually talk about why you've invited me here today, which is, to talk about critical enablers, which is kind of what you see on the right side of the screen. There's several enablers, and there's several enablers out there. It's hard to do everything in a 20-minute presentation, but what I've listed on the right are the ones that I consider to be the top 4. And I'll just go through each one quickly, and then I've included a few slides as case studies based on recent work that we did in Nigeria. The first thing is, and we say this to clients all the time, is that you need to find a good distributor, right? And I think the concept of having a distributor in global health is one that we don't really think about. But I mean, at the end of the day, if you want to get your products into the market, you need distributors. It's important because with contraceptives, you have donors buying, but then you also have a huge market in the private sector. And you also have government agencies that float tenders, which usually a local agent has to respond to. And if we want to expand coverage to contraceptives, we need to be able to go to places where oftentimes the infrastructure that we've built in public health doesn't get to. And so this is where distributors come in, because they build that infrastructure, they have the sales force, and they can go out and market the product to pharmacies, they can market the product to private hospitals, they can market it to retail outlets who interface with many of the patients that we're currently not reaching. And later on in the presentation, I get into reasons why this specific class of products, the long-acting contraceptives, for example, just isn't very attractive to distributors. And I highlight some of the things that we can do to change that dynamic. The second critical enabler is financing, and this is a big one, and it's one that we struggle with all the time because it's not easy. To scale up access to contraceptives, you need a diverse range of funding options. The way I like to think about it is to put people into financial archetypes. So archetype number 1 is you have people who see the value in contraceptives and are willing to pay something for it. For these people, cost is an important driver. And so, subsidizing the product goes a long way. And this is what many organizations do already. Donors are already subsidizing many of the contraceptives that are coming into the African market. And I think that work needs to continue because the willingness to pay just isn't there. So that's the first piece of financing. I think then you have a whole community of women that are on health insurance schemes who can benefit from contraceptives, but who currently won't be reimbursed by their health insurance providers because contraceptives are not on the benefits package. And I find it just very it's strange, right? Because contraceptives are not we're not dealing with a chronic infection or disease here where you need to put the person on lifelong treatment. These are solutions that are very cost effective. And so it's shocking that you don't see enough health insurance providers covering contraceptives. And I think the intervention here is very straightforward. If we can get the social health insurance providers that reach poorer communities and the private health insurance that are dealing with the well-off people to cover contraceptives, then what you do is you reach millions of people. And again, later on in the deck, I show examples from Nigeria. And then you have people who can afford it. And for people who can afford it, they can't pay out of pocket or they are not on health insurance. These people will need financing products for free. And so, the government will need to provide that, and donors would need to step up as well. That is the reality. So I think with financing is critical, of course, and we need to think about, across these three archetypes, how do we engage and what instruments do we use? Third enabler is the private sector, and I think the private sector is critical, right? Pharmacies, private facilities, hospitals provide healthcare to a significant amount of people in many of the settings where we work. In fact, in some countries, they provide most of the care. And even when you go to hard to reach places or in communities where people are displaced, you would always find a drug shop. You would always find a drug shop. The quality might not be great. They might not have a lot of drugs in the store, but you will find something. And so so if we want to expand coverage, we need to figure out how to bring these people in. They are a fundamental partner. I think the challenge we see with the private sector is that they run on different incentive schemes to what the folks like us are used to. And I don't think we've completely figured out how to incentivize them. But if you provide them with the right incentives, they're pretty effective at getting your products anywhere. And the last one is just demand generation. And honestly, I don't think there's nothing to say here. It's sad to see that over the years, and it's not just a contraceptive issue, you see it across other product classes as well. There's been a lot of focus on the supply side and demand side. People say, well, we leave that to the government. But the truth is there's just no money. So the only way your supply side interventions will succeed is if you also invest heavily in demand creation. So that work has to be done. Next slide. And then the next one. So I just wanted to I put some things in here to buttress some of the points that I just made. We did some work for a client over a year ago looking at the SRH landscape in a number of African countries and what we can do. And what I'm showing, and so the next few slides are a case study on Nigeria. What you see here is our own interpretation of how products move from the manufacturers to, across the value chain, right? And what I highlight in it's yellow, I'm colorblind, but it's yellow, are the key, the open market in Nigeria plays a very, very important role. So the open market in Nigeria is literally a market. It's a market, and they have different drug shops. And these not drug shops, wholesalers. These wholesalers basically sell different things. And when, the social marketing organizations, for example, they're running low on stock, they go to the open market. When hospitals want to buy a product, they call up someone who goes to the open market, right? When the NGOs want to buy and so on, the open market also bids directly to government tenders. When you ask most people in our industry, they call this informal markets. They say we don't know what they're doing, they're informal. They're not informal at all. They are very organized, they have structures in place. They account for maybe 50% of all the products coming into the Nigerian market. And we don't really engage them, right? So very, very critical that we engage the open market. And then these open market people sell to distributors as well. And then the distributors sell to, the private sector, the retail shops, PPMVs, private clinics, and so on. So the point here is, imagine if you could better engage these people. You have distributors that know how to get products into northern Nigeria, the places where none of us want to go. They're getting products in there. Imagine if you could engage them on contraceptives. Imagine what impact that would have on coverage rates. So that's one point. We need to think about the open market and the distributors that serve that open market and how we can bring them into the fold. Next slide. And so we've also looked at, people talk about markups all the time, right? And that they're like, these guys, the markups are too high, blah, blah, blah. And so we have this illustration, which is not by any means the fact. We've looked at across a range of products, the different markups that one will charge, right? So assuming the product lands at $10, you pay interest on the loans that you take to procure that product, because that product is not given to you free of charge. And sometimes you're taking interest rates of between 15 to 25%, and you need to pay that back, right? And you sell the product and you're not paid immediately, right? So it might take 6 months for you to get payment. You have the clearing and import taxes. Then you need to get registration. You have the marketing authorization fees. Then the distributors have fixed costs because they need to do sales and marketing. They have warehouses that they need to deal with and so on. And then you also have middlemen, because that distributor in Lagos maybe doesn't know how to get products into northern Nigeria. So he gives the product to a sub-distributor that knows northern Nigeria that puts his own markup. Then you have your gross margins because you need to make money. And then you sell it to a pharmacy, or you sell it to a private hospital, and then they put their profits as well. So you can see how it goes from $10 quickly to about $33, right? And this is the cost of doing business. So you want to engage with a distributor, you want to engage with the private sector, right? We need to think about what those incentives are. Like, how can we shave off some of this cost? How can we help them with registration, for example, so that they don't have to pay that marketing authorization fee? How can we, work alongside the distributor and their sales agents on demand creation and so on, so that maybe they cut out the middlemen? I think we can think creatively about what we can do here. Some of the things that we've also found is that in many markets, these products are also donated, right? So on one side, you have a pharmacy that is selling something, and they've built in all these costs. And then next door, you have a product that is given for free. And what we don't talk about is some of those free products make it back into that open market, and that is sold to distributors as well. So again, we're not creating incentives, because when there are leakages, then as a distributor, as a private sector company, I'm like, why should I even get involved in the first place? I'm going to spend my money importing this product, or I'm going to spend my money putting this product on the shelf. And then next door, somebody is getting it at a highly discounted price because it's leaking from the public sector. I'm not going to touch it. So I think these are some of the realities that we need to deal with if we want to engage with distributors. But some of these principles also apply to the private sector. Next slide. We looked at health insurance as well. We're like, okay, a range of, and this is not exhaustive, just a snapshot of the big health insurance providers. We said, okay, private health insurance, do you cover SRH commodities and also the national health insurance? What we found is many of the private insurers do, because again, they're insuring relatively well of people. The premiums are very high, so they don't have a problem reimbursing, IUDs, injectables, and so on. But then for the national health insurance scheme, we couldn't find any evidence, for example, that is being reimbursed. Lagos state is the only state that is reimbursing it, and this is relatively new. And so what this tells me is that there is appetite from the national or social health insurance providers to reimburse family planning. The thing though is that again, it's how do we engage them, right? We're used to saying we're going to do investment cases and this case and that case. The truth is the decision on what goes into the benefits package is not. There is the process on paper, and it's very methodical, but then a lot of it comes down to politics and who you know. And so we have examples from other countries where it's taking a company to get a life-saving product into the benefits package. It's taking them 5 years. And then we have another example in that same market where it took 6 months for a product that did not make any sense. So again, it's just realizing these nuances and figuring out how we engage. But I think there is a huge untapped potential with the health insurance providers. Next slide. Okay, and then we also got some insights from the private sector. Like we asked them, why are you not, deploying LACs? And I just wanted to share some of the feedback that we got. They talked about awareness about specific methods. It drops significantly outside of the big cities. So the providers and users in Nigeria, a lot of them outside of the big cities lack the awareness of the features and the benefits of family planning methods. Also, end users and community pharmacies remain unaware of certain methods. So I think it goes back to the earlier point about awareness generation and demand generation and so on. And as we think about the next generation of contraceptives, right, it would become even more critical that people are aware of what is coming down the pike. And when these products are on the market, they are aware that these products are on the market and how to use them and so on. There's generally low demand and for this specific class of products, and because there's low demand, right, because there's low awareness, there's low demand, private sector folks are just like, why should I touch it, right? I could be selling anything. I could be selling paracetamol. I could be selling antibiotics. Why should I put my money into this? So again, thinking about incentives, if I'm a private sector hospital or I'm a private sector pharmacy and I don't need to use my cash to pay for a product, you are coming to me and you're like, look, sell this or give it to the people that are showing up in your hospital, but you don't have to pay upfront for that stock. That is an incentive. I will take it because I'm like, there's very little risk. I just need to sell it. So thinking about incentives for the private sector. The third is limited training opportunities on product administration. This was also raised that upskilling is needed and task shifting. A lot of that is happening already, but for example, nurses are often overlooked. Again, this is outside the big cities, despite them already having trainings on surgical skills, for example, to administer lacs. There's a fourth point around Forex. I've talked about this already. It's just difficult for people to access USD. And so it just limits what they're willing to stock. Like the slow-moving goods, nobody touches it, right? If I'm going to spend so much time accessing Forex, I want to be sure that I can sell my products quickly. Next slide. And then I think this is the last one. Oh, that's it. So, main takeaway is that, look, we know what needs to be done. I think we have several opportunities, and we need to just, really think outside the box. Think less like public health, global health people, and think more about like the incentives and interventions that we can offer to some of these players that do not really operate within the circles where we engage. Thank you.
Thank you very much, Olawale, for for a very comprehensive presentation. I think you have challenged us to think very broadly, and you have brought up some very critical points. One reality that is in the continent is that there are free products that are coming in through donors and even government purchasing. And with that, then the incentives, even for private sector and for distributors, then hits a challenge. And so when we talk about total market approach, what does that then look like? The other that I did like was the fact that you rightly said that there are partners who are not part of the normal, global health scan, as it were, who have the ability to provide services, and that, we really need to put effort collectively to reach those partners, especially when we are thinking about introducing new products. And then the demand creation, very critical that this happens, for existing and for new methods, that those, particularly that part goes on, and that the capacity building extends even to private sector. In many countries, pharmaceutical firms have partnered with governments and put in an introduction program that covers large parts of public sector and a private sector. So I think that there are models that exist on how that should be done best. But you make a great case for that often the skills building is leaning towards the public sector. And then finally, the issue about nurses. So it's interesting to note that in Nigeria, that the nurses tend only coming to the table now. in the eastern part of the continent, nurses are actually at the forefront of providing some of these long-acting and reversible contraceptives. So, interesting contrast there, providing an opportunity for learning, of course. So thank you very much for that presentation. Definitely a lot of food for thought. The fiscal space. Yes, will RH commodities be prioritized when it comes to trying to divide, that cake, as it were, and therefore, that lends itself to advocacy. And I know that we will be hearing a little more about advocacy later. Now, I'd like to move us to our second topic, and that will be presented by Clancy Braxton, and she is a private sector team lead with USAID Office of Population and Reproductive Health in USAID Washington. She has more than 20 years leading, managing, and overseeing family planning, reproductive health, and HIV investments in social marketing, social franchising, private sector health, and social and behavior change. She is currently leading a team of professionals who are providing grant and technical management to the frontier health markets, to an activity called Momentum Private Healthcare Delivery, and another activity called Shops Plus. So without further ado, I want to welcome you, Clancy, to tell us about the global case studies that are there to drive access for these new products. Welcome.
Thank you. It's great to be here today. I'm going to present on two analyses that USAID commissioned. One is focused on demand estimates for product introduction, and the other is focused on market sizing of the Kaya diaphragm. Next slide. The genesis of this first analysis on discerning demand was that several colleagues at USAID shared a sentiment that perhaps funders aren't doing enough to understand the actual demand for new products that are designed to be procured and to be bought by governments. We noted that a lot of terms for demand are used interchangeably, and that demand is often conflated with need. And it may as well be conflated with language describing the total market. So this thinking brought together a group of people led by Global Health Bureau at USAID, Center for Innovation and Impact, to develop the Discerning Demand series of papers. Next slide. So these are some of the individuals that contributed to this effort. I'm noticing the slide is not updated, actually. Apologies for that. The 11 core advisors provided inputs representing different funders and practitioners, and then 100 subject matter experts from many different groups provided inputs as well. That included stakeholders such as NGOs and implementing partners, universities, innovators, manufacturers, as well as many country colleagues. And the goal was to get a broad understanding of global health product development and investments. Next slide. Stepping back, the report objectives were threefold. Most importantly, we wanted to define what we meant by demand, to clarify how global health stakeholders account for demand, and to make sure that definitions of demand were understood well. There was also an effort to assess available approaches and tools and to offer recommendations on best practices and collective action. Next slide. So USAID launched in June 2023 7 resources on this topic, and I encourage you to go online and Google Discerning Demand USAID papers, and you'll find these 7 resources. They include a brief report summarizing all of the information that was gathered, a supplemental of landscaping of tools used to assess demand, and 4 product retrospectives that offer learnings on the scale and the role of demand in that process. And we selected those 4 product retrospectives through a consultative process. Next slide. In this presentation, I'm going to focus on the product retrospective on the internal condom. So to introduce you to the internal condom, it was previously known as the female condom. The name internal condom honors diverse genders and men who have sex with men that use this product. It's a single-use, dual-purpose product. It was developed originally as a contraceptive device, but with the dual purpose of preventing unwanted pregnancies and reducing STI transmission. And the product was had few suppliers initially. The expected payers were the Global Fund, PEPFAR, and UNFPA. Now it's available in over 54 countries globally around the world. I think the uptake has been mixed. So currently it's less than 2% of women of reproductive age using contraceptive methods, despite having a wide range of donors and funders that have backed the product over the years. So this internal condom retrospective also looks specifically at the Path Women's Condom, which was manufactured by Shanghai Dahua. And that product was developed with funding both from the Office of Population and Reproductive Health at USAID, as well as the Office of HIV/AIDS at USAID, and several other donors, including the Bill and Melinda Gates Foundation and the Netherlands Ministry of Foreign Affairs. It was designed to be a better female condom, a better internal condom. Human-centered design was used to design a product with characteristics that would overcome some of the problems we'd seen previously with the original female condom. And despite that design and funding from donors over a significant period of years, the women's condom was never able to gain much traction globally. Cost, in particular, was a major barrier to uptake for the women's condom, since it cost 80 cents to $1.41 per condom. Next slide. So it's taken over 30 years for these products to go from design to where they are today. Ultimately, at USAID, our interpretation is that uptake has fallen short of expectations, and there's a variety of reasons for that we'll go into shortly. Over the timeline of development, you can see FC1 started in the 1980s and launched in 1992. Then there was the FC2 design that was based upon user feedback received from FC1. It was designed to be thinner and quieter and made from a different material. But the design was similar in shape to FC1. And then, as I mentioned, the women's condom was developed to be an improved version of the internal condom beginning in 1998. And the designers used a human-centered design approach to come up with a shape that is composed not of two rings, as in FC2, but rather one ring and a polyurethane pouch enclosed in a capsule. And the capsule dissolves upon insertion. And so, and the internal condom itself is held in place by foam pads. So this women's condom followed a path of ideation and design, and then it had performance and safety studies. In 2010, the women's condom gained EMA approval in the EU, followed by a variety of other regulatory approvals. USAID funded several pilot introductions in Malawi and Zambia, as well in 2016 and 2017. So there's quite a lot of investment over time and quite a lot of development to improve internal condom offerings and to develop the women's condom as an improved internal condom. Next slide. So what we've learned from the experience of the internal condom is summarized here and in the internal condom retrospective. Most importantly, I think we've learned that there is a need for a strong value proposition for new products. And so this particular product struggled to be valued amidst competing products that scaled up over the course of the internal condom's launch and introductions. So during the time that the internal condom was being developed and refined, the HIV prevention community was focused on other products, on male condoms, and then eventually on oral PrEP. And so the HIV prevention community was less focused on condoms over time and less focused on internal condom. The family planning condom and family planning community as well was focused on LARCs during much of this time. And as a result, end users faced an increasingly competitive landscape of choices and options. And so we've learned that we need to be clear as we move through the product development and introduction process about where is the value proposition and how might it be changing over time. We've also learned that investments in demand activation are extremely important and need to be funded. These investments are often the last priority in the product development and launch process, but we think we need to rethink the importance of these investments and the timing of them. So first, we would need to rigorously push for the value proposition of the product, and then we would need to earmark funds for demand activation through channels closest to those planning to use it. A third set of learnings is that inappropriate demand sizing can really harm our efforts to introduce products and our success long-term. So in the case of the internal condom, initial market sizing was done based on comparisons with the male condom, despite gender differences, and that led to an overestimation of demand, of potential demand. And in addition, some of the design features of the first internal condom, the FC1, were not assessed prior to the launch, and that probably impacted initial demand. Another issue was that user promotion language that was effective in North America and Europe didn't transfer to LMICs. And so marketing materials and demand creation from those settings in high-income countries were not relevant in other settings. And then finally, there was a misalignment between user and payer needs. Even though the PATH women's condom, it accounted for user preferences, but it couldn't meet the price expectations among payers, especially when compared to other more affordable products. So overall, at USAID, we're trying to apply learnings from this publication to other new products we're investing in. For example, we recently looked at market sizing of the Kaya diaphragm, and I'll talk about that next. And we've seen that even in cases where we can do accurate demand sizing, we often don't have enough data on user preferences amidst choice. And so we're taking the learning from this publication, as well as from the Kaya market sizing, and trying to apply this across and looking at other products. And we hope that this learning will be useful for others engaged in these areas as well. Next slide. So this is a finding from the 4 retrospectives of the Discerning Demand publication, and those are across global health. So I focused on the internal condom, but here you can see the pitfalls that were identified across the 4 product areas. And I think some of those that are most relevant to mention here are that we do see a disconnect often between what end users want and what global health advocates and innovators think that they want. We also see a lot of variation in demand sizing. Typically, the variation is driven by a lack of clear definitions of demand. And so we need to clarify our demand sizing and how it's done and what those definitions are. And finally, we often see something called continuation bias, where global health stakeholders sometimes want to prove something is worthwhile rather than pivoting or stopping an investment path they've already started. So sometimes there is this bias to continue with things that we believe in, we feel are important for equity purposes, but there may be an uncertain future for who will pay for the product and how it will enter markets. Next slide. So we ended up with 2 types of recommendations coming out of this. The Discerning Demand paper overall noted 4 best practices for individuals to adopt. They are applying standard definitions of demand, incentivizing organizational norms that reward pivots, adapting stage gating processes to the global health context, and continuously pressure testing demand and purchasing signals. So in the interest of time, I'll let you review the ideas for collective investment on your own. Next slide. Okay. Sorry, next slide. Next slide. The next section will focus on a market analysis of the Kaya diaphragm. Next slide. So over 20 plus years, the Kaya was a contraceptive option developed to be easy to use, hormone-free, and reusable for 2 years. It has a single size design, so it fits most bodies comfortably. And it's easier to supply than traditional diaphragms because it doesn't come in a range of sizes, so it doesn't require a physical exam by a healthcare provider. In many countries, it's available without a prescription and can be purchased over the counter. And it is labeled for use with a contraceptive gel, such as Kaya Gel, which is a lactic acid-based contraceptive gel distributed by the manufacturer, which is Kessel Medington. So once launched, Kaya saw significant success on its own in high-income countries. The manufacturer has been marketing and selling the products in about 40 countries. At the same time, Kaya has been piloted or introduced in only a few low-income countries and remains relatively unknown given the investments in developing it. So we set out, we worked with the Boston Consulting Group to understand the market challenges related to Kaya and next steps for the product. And the objectives of the analysis were to identify what is known and unknown about the market for Kaya, to build an estimate of demand for Kaya, and to develop a high-level view of Kaya's potential. It did not aim to provide an exact estimate of expected Kaya uptake. It was rather an estimate, a directional view of the potential user share in order to make decisions around Kaya. Next slide. This slide provides some background on the current state of the market for Kaya. Kessel, the manufacturer, works with local partners to distribute the product. And they estimate they can capture 1 to 5% of the contraceptive market, depending upon current uptake of contraceptive options and product mix. The product currently has its strongest presence in high-income countries, particularly Europe, is distributed there over the counter, and has captured, for example, about 1% of the contraceptive market in Germany, and 425 diaphragms have been sold so far in high-income countries. In middle-income countries, Kaya has been expanding, has been registered and introduced in the majority of Latin American countries. And in low-income countries, introduction has slowed after pilots and introductions in Niger, Benin, and Nigeria. And additional resources are needed for low-income countries for product purchase, training of trainers, and demand creation and marketing. From a global perspective, Kaya has been seen as reinvigorating the diaphragm market, particularly in high and middle-income countries. Before Kaya introduction, diaphragm sales had been dropping for decades. And now Kaya is the most widely distributed diaphragm globally. Next slide. Based on Kaya's success globally, USAID asked BCG to determine the serviceable addressable market for Kaya in sub-Saharan Africa. So the serviceable addressable market was defined in the Discerning Demand paper. It's also used widely in business to estimate the market that is the subset of women from the total addressable market that are interested in non-hormonal options with Kaya's characteristics. So in general, the serviceable addressable market is a business-oriented demand estimate. It outlines a segment of the total market that is targeted by a specific product and that is within the relevant geographical reach. And for the purpose of this analysis of the serviceable addressable market, the geographic area was defined as FP 2030 countries in sub-Saharan Africa. Next slide. This slide shows the assumptions that we incorporated into the analysis. I want to note that there were a variety of assumptions that were made, and the assumptions can be quite important to any analysis of this type. So we recognize there are likely assumptions that might not play out in this way specifically. And we also asked BCG to conduct sensitivity analysis that would take into account the upper bound and lower bound estimates, depending on how true those assumptions turned out to be. So while the analysis is imperfect, it is a reasonable approach that a business would take to understanding the potential for a new product in a relevant market. And for that reason, we think it is a useful metric to help better understand Kaya's market potential. Next slide. With the current labeling of Kaya, the BCG analysis estimates that Kaya could capture about 250,000 new users in sub-Saharan Africa. 70,000 of those users would be new contraceptive users, while 180,000 would be switchers from another contraceptive method. Again, it's important to note that these are estimates only and are not exact. And they are estimates that are in the absence of significant SPC or marketing campaigns that might be able to increase the percentage of users that Kaya is able to capture. It assumes adoption based on the current business model, which includes some demand generation, but without a very significant push to increase demand for the product. In addition, next slide, we asked BCG to look at the potential for the Kaya market if the product were to be relabeled so that it did not indicate use of Kaya with the gel. The gel has cost implications as well as product distribution implications that make it more difficult. So we wanted to see that if you took out the gel, if it was relabeled, and that would require a study and regulatory approvals that could be expensive. But if you did that, could you increase the market size? And we saw that for a no gel label, BCG estimates that Kaya could capture an additional 590,000 users, with 160,000 users as new contraceptive users and 430,000 users as switchers from another contraceptive method. And again, these estimates are for FP 2030 countries in sub-Saharan Africa and the potential market size there for this product. Next slide. So these are the key findings from this Kaya market assessment. First, considering the limited range of non-hormonal methods available, Kaya is uniquely positioned to address specific demand for a non-hormonal, on-demand, user-controlled method. And that was demonstrated in its positive uptake in several pilots in sub-Saharan Africa. At the same time, the value proposition for Kaya in low-income countries is varied. The market size for Kaya could be about 250,000 users or up to 600,000 users with the change in label, which is relatively small, depending on how you measure it. The issues, there are some issues with the gel that in terms of cost and distribution that would need to be overcome. Contraceptive effectiveness of diaphragms is a little bit lower than LARCs. And there's a requirement for intense demand side support for this product. Next slide. So some overall conclusions. Moving forward, we think that international agencies and partners can contribute to Kaya markets by looking for markets where Kaya is a particularly good fit for expanding contraceptive supplies, by considering a label change for Kaya to allow for expanded market size in sub-Saharan Africa, considering a partnership a public-private partnership would be well placed to prime the market for Kaya and to create demand in new markets, and to use behavioral research tools that could help us better understand the trade-offs that people face when choosing between methods. And that was a finding of this work, is that many times we don't really understand the trade-offs when people are choosing between methods, why they would choose one method over another. Even if they report a preference for one type of method or another, sometimes when they actually are faced with the trade-offs and the costs involved, they don't behave in the exact same way. So better understanding of user preferences and actions would be helpful. Next slide. Some additional observations. My expertise, as noted at the beginning, is in private sector engagement and service delivery. So I've included here some observations on facilitating contraceptive access using the private sector. Partnerships are an important opportunity for us to expand access to new contraceptive technologies. In particular, partnering with manufacturers allows us to work with them so they can plan for product introduction, including forecasting, training supplies, and other efforts. In addition, private sector service delivery sites and pharmacies offer unique outlets to make new technologies available to a wider range of clients. Health systems approaches focused on the market development approach offer the opportunity to improve health systems and expand access to new contraceptive technologies. And market shaping efforts can reduce prices and can expand contraceptive access, but they must be used carefully and must be devised in conjunction with payers and procurers in order for them to be successful. Next slide. So some final observations, and I know I'm probably running out of time, but both of these publications have brought us back to some questions around what our end goal is in trying to expand the method mix by developing new contraceptive technologies. So if our goal is large changes in CPR with game-changing products, then we need to learn from these experiences and past experiences relative to the importance of understanding demand estimates, the importance of stage gating approaches, and examining market size. And if, on the other hand, the focus is equity in contraceptive availability, and the goal is user-led, context-appropriate, and gender-inclusive contraceptive, then we will sometimes have some hard trade-offs that we need to consider. While we will likely get better continuation in contraceptive use with a variety of personalized options, we may not see the high number of users per product that make the investments in subsidized products, substantial demand creation, and training of providers worthwhile per users. But if we think a higher investment for certain populations is worth it, we need to be honest about the increased funding levels required per person to reach those populations. And it's important to have our eyes wide open about the costs and trade-offs of certain products as we develop and launch the technologies. So thank you, and a special thank you to all those that helped USAID develop this work, especially BCG, PATH, Kessel, Med, and Tim, and others.
Clancy, thank you very much for a very interesting presentation, bringing a lot of findings and stimulating us to think of a lot of factors. One of the things that I think was really important, what you said, is the issue of discerning demand, and what do we mean by that? And then secondly, you raised the very valid point that sometimes the global landscape don't have a complete understanding of the country priorities and the financing landscape and even the political will. And so it's so important to begin with asking ourselves, what's the problem that we are trying to solve? Do we understand the users in these countries? And do we also understand the financing landscape? Because in countries where there's largely donor funding, and even where there is government, it's not yet at the level of the donor funds, then it means that one must think, one, where will you introduce that product? And you've talked about private sector. But, you know, beyond that, is there opportunity for that product eventually to get into public sector, and who will finance it? And then all the package that goes with introducing a product into a country, and, you know, with regard to the demand creation and making sure people are trained, the product is in place, the supply chain is in place. And, you know, many times countries will start with the introduction in a small way. Is there the long-term planning? So it is a complex process, and yet very necessary. And there's definitely been very good lessons learned from the work on the internal condom, the PATH's women's condom, and also Kaya. The other fact, of course, is that increasingly users especially amongst the younger population who are educated and have access to the internet, they have a lot more information, and therefore they really will be asking a lot more questions about the products. And if we're talking about the future, then we're talking about, you know, this population of young people. And so, you know, the need to keep that in mind, understanding the context, but also knowing that we're dealing with a generation that have access to so much information, will have so many more questions. You know, in the last 10, 15 years, there has been a heavy focus on the long-acting and reversible contraceptives. And, you know, as one looks at that, you know, at the back of your mind, you're always careful that you are, you're not tilting programs to a certain way. And by that, I mean that women and young women and older women are getting full information about, the method they choose, but information about their methods writ large. There are many lessons, of course, that we have also learned from the introduction of DMPA sub-Q, which has, entered into private sector. So thank you once again for your presentation. And, what you have captured is the complexities, that exist at global level as different players, consider introducing products. And then we heard from Olawale before about the health systems. Now, when considering the market and the demand for the product, what is important is to have to think about how will the country process move. And this is where we get into the advocacy part of it. And so at this point, I would like to introduce Wanjiko Manguyu, who is an accomplished public health professional with over 12 years experience working in advocacy for reproductive, maternal, newborn, child, and adolescent health. In her current role as a regional advocacy and policy advisor at PATH, Wanjiko provides technical support for the development of advocacy strategies, supports policy review and development, establishes and maintains advocacy partnerships, and strengthens the advocacy capacity of various institutions and public health individuals at regional, national, and subnational levels in East Africa. Wanjiko's family planning advocacy has been focused on the scale-up of DMPA sub-Q at national and subnational levels in Kenya. And so we welcome you now, Wanjiko, to tell us about country-level advocacy as we consider the introduction of new products. Over to you.
Great, thank you. I hope you can hear me.
Yes, very well.
Thank you. Thank you so much for having me. I'm really excited to share some of our perspectives when thinking about advocacy, particularly for introduction of new products at country level. So just to provide some context to what we've been doing at PATH since 2022, we've been providing strategic insights that inform family planning and the broader women's health advocacy strategy. Some of this has included work around landscaping and development of a policy framework for expanding private sector options for family planning. We've looked at messaging around contraceptive technologies R&D. We've developed recommendations for identification and cultivation of champions. And we're investigating the application of contraceptive technologies R&D framework to a broader women's health product portfolio. So today, I'm going to be focusing on the development and application of a policy advocacy framework for contraceptive technology R&D. So from now on, CT R&D. I'm going to just describe the scope and the methodology that we used. I'll share some of the lessons from successful global health R&D advocacy efforts. And I'll highlight some of the unique challenges for CT R&D, and then just spend the rest of the time describing the framework and the implications for improving access and investments at country level. So we can move to the next slide. Next slide. Great. All right, thank you. So as we know, the funding environment for contraceptive technology R&D is really limited to two donors, so US government and BMGF. While very committed, they can't shoulder the cost of this indefinitely. We are well aware that contraceptive method choices are needed to meet the diverse needs and preferences of women and men at different stages in their lives. But we're continuing to see persistent weaknesses within these markets that's resulting in millions of people just not being able to access comprehensive, high quality, affordable products that really match and fit their preferences. So with that in mind, establishing a stronger enabling environment for CT R&D should drive diversification among the potential funding pool, as well as facilitate the development of products that best meet particular user needs. So as I mentioned earlier, since 2022, we've been doing this work on developing a policy environment. And the goal of that is to catalyze the contraceptive technology R&D, drawing on lessons from successful global health R&D advocacy efforts, and applying them and identifying those unique challenges to product development and introduction for contraceptive technologies. So as you see there on the screen, our methodology included conducting an in-depth literature review. We convened a series of stakeholder interviews with contacts from the FP community and broader global health R&D communities. We used these findings from these activities to develop the advocacy framework that you will see later. And this advocacy framework identifies an ideal state for contraceptive, for CT R&D, and identifies the policy issues and approaches that can enable that ideal state. Next slide, please. So we spoke with colleagues, including those working in HIV, TB, malaria, and microbicides. And we did this to gain their perspectives on the various advocacy tactics that have been most impactful in addressing R&D policy needs, and then drew the lessons from various publications on the same. So I'm going to highlight some of the lessons learned. We centered them around 5 broad themes. One was on generating political support. Advocates continuously cited how critical it is to establish a clear value proposition, similar to what Clancy discussed earlier in her presentation. A clear value proposition that appeals to a wide range of diverse stakeholders. And these propositions often link to other issues such as gender equity, economic and development gains, or social justice issues. The second theme was around developing a cadre of advocates who are aligned on an issue and informed about the R&D process. So in several global health R&D communities, so what we've seen from the TB, HIV, and microbicides communities, a lot of effort had been taken to build advocates and communities R&D literacy. So this was either through direct engagement with the researchers, community education about ongoing clinical trials, or just building their expertise on topics on efficacy versus effectiveness. What we've seen is that there are significant gaps on the inclusion of women's voices across the R&D value chain, but I'll speak to that a little bit later in the presentation. The third theme was around advocating for research to be rooted in community realities and market needs. Again, linked to the discussion we just had around how demand is conflicted need, or just really discerning what demand actually means. We're looking at inclusion of end users. So this includes consumers and healthcare providers, private sector, and others. And so in this way, we're making sure that we're developing products that actually meet the needs of the communities. The fourth theme was around timely licensure for products. There have been efforts to streamline these and to harmonize regulatory review processes. We've seen some successes with neglected diseases. However, there's still room to grow. We're still seeing that even with these harmonized processes, we're still at times failing to reduce the timelines around introduction and of new products. And then finally, planning for introduction and scale-up needs. This must take place early, and it must be continuous. It should not just be a one-time event or something that comes through later on in the R&D process. Time and again, we've seen that the thinking around product introduction has been delayed, and then this then results in sort of market or policy needs that haven't been anticipated, including financing to cover the costs related with introduction. Next slide, please. So we did identify some characteristics for CT R&D that are actually unique when compared to R&D for other global health issue areas. So, for example, when we're looking at political support for CT R&D, we've often seen that this is inconsistent. So funding has paled in comparison to other global health topics. Unlike other global health disease areas or issue communities, which have largely embraced the need for R&D in recent years, support among the FP community about the need for CT R&D is somewhat mixed. And this may be derived from concerns about, you already have limited funding, and concerns about how this limited funding could possibly be diverted from essential programming to fund R&D, or that new technologies are only desired if they meet consumer needs in new ways or they replace older methods. The other unique challenge we saw is with R&D processes. These have sometimes not been very clear or consistent across countries. CT R&D has largely been left out of efforts to harmonize and streamline regulatory processes, both at regional and at country level. And so we often see there is no sort of global consensus about some of the research priorities, specifically for CT R&D. The other thing is that while global health markets are often challenging, there's still additional hurdles for new contraceptive technology contraceptive products. Recent experiences with introducing new injectables, so DMPA sub-Q or implants, they've faced issues around low consumer demand in country or unaffordable pricing at local level, inadequate funding for the introduction, and also concerns just generally about waste management. Next slide, please. So this is what I mentioned earlier. So we looked at the inclusion of women's voices in health R&D more broadly earlier this year. And what we were trying to do was to investigate the inclusion of women's voices in processes. And we did this in Kenya and Nigeria to begin with. And we were looking at the enabling laws and policies that elevate women's voices, the active involvement of women across all phases of the R&D chain. We're looking from policymakers to researchers to participants to end users. And we identified some gaps, which I'll just briefly touch on. We had three sort of buckets in terms of gaps. One was enablers. When we're looking at enablers, we're talking about the presence of enabling laws and policies. And so generally, while we might have several like gender inclusive policies, frameworks, and bodies, the implementation has been impacted by systemic or sociocultural realities. When we look at representation, which in this case is the active involvement of women in the rollout of health products across all phases of the R&D value chain, we noted that while this is trending upward, women are still underrepresented in leadership roles due to various factors, stereotypes, biases, cultural beliefs, practices. When looking at the bucket around support, and for this, we are talking about the degree of women's access to capabilities and resources to influence women's health R&D, we noted the need for tangible support that is dedicated to achieving effective inclusion of women. So we need supportive mechanisms. Next slide, please. So this brings us to the CT R&D advocacy framework that we have developed. we feel it's time for a radical shift, and that the global SRH community really needs new approaches to tackle barriers and equip more people with products that match their needs. So this slide shows the framework we have developed as a response to the information that we have gathered. And our aim is that high quality, affordable products that meet end user needs are available at all outlets. And in our view, there are four key components of an enabling environment for contraceptive technology R&D. I will try and infuse a little bit of our experience from our long history of driving the development and scale up of user-centered innovations in women's health, so specifically for DMPA sub-Q. And for those of you who are unfamiliar with DMPA sub-Q, it's a small, easy-to-use injectable contraceptive that allows women to have the autonomy over their own health and expands access to contraceptive options. So I'll throw some of those examples from the work that we've done in Uganda, Kenya, and other areas. So the first key theme is around incentives to stimulate R&D. As I've said, CTI R&D has historically been underfunded. And what we are looking for here is what we would like to see is a costed global research agenda that is developed in consultation with diverse stakeholders, including Ministry of Health, researchers working from lower middle income countries, providers, end users, donors. So in the DMPA sub-Q context, we saw that there was initial hesitancy by some of our governments around the use of DMPA SQ. And if we had evidence from the manufacturer on the product use in those communities, it would have resulted in much less need for sort of smaller localized pilots and supported faster introduction. The other thing is looking at robust funding. We have identified that we need funding from a range of well-coordinated and aligned donors. The FP community in this case stepped in and to finance the introduction and scale up of a DMPA SQ in lower middle income countries. And that included funding local research pilots that facilitated approvals. So responding to specific needs coming through from local contexts within countries. The second key theme is around systems to support ethical and inclusive research. So policies around systems to support ethical and inclusive research. We see that new tools are frequently designed and implemented, but these are often done by global actors who have little engagement with consumers or interaction with the actual health systems where these technologies are actually going to be introduced. So what we are looking at here is ensuring that we have research that integrates the views and priorities of the users on aspects such as the product decisions, uptake, how health providers are trained, and the inclusion of decision makers across the policy process. The other thing was to look at having strong and sustained capacity. So making sure that in these countries, you had researchers that were included from the beginning and that led the actual pilots and implementation science that informs any policy adaptations. The third thing was around clear mechanisms to assure quality products reach consumers. So here we're looking at the fact that regulatory pathways for new methods, they're not very clear and often not streamlined, and this causes delays in making products available. So there are opportunities here. So for example, the newly developed African Medicines Agency And that can act as a facilitator to ensure products are introduced with fewer delays. Some of the harmonized regulatory processes that are happening at regional level and being ratified at country level should help facilitate these processes as well. And in most cases, we see that without these clear guidelines to aid introduction, we just have continual delays. The fourth category for policy is around market development, so that affordable products are available when and where FP consumers want them. So what we often see is a lack of planning for introduction needs. This has been spoken to before in a previous presentation. So this lack of understanding of consumer demand and planning for policy change. So, for example, in our case, when we were doing the introduction planning and scoping and working with our stakeholders, we made sure that those were engaged early and consistently, and that the evidence generation was directed and served and answered the needs and questions of those local stakeholders. I think we can move on to the next slide. So the implementation of this policy framework has to be supported by an informed and engaged cadre of advocates and champions. Having a clearly defined proposition is necessary so that you have a diverse advocates, whether they're working at community level, whether they're working within policy spaces, whether they're working within the health system in terms of providing services. Having that ensures that you have advocates who speak with confidence about the research issues, and having these champions be well positioned to call for funding and policy change. So having these LMIC champions at country level, at subnational level, is critical to any success of any introduction of or scale up of any new products. Cultivation takes a long time, so you need to be sensitive to the availability of local evidence, and then to understand the sort of political shifts that happen within countries. And so for the implications, I'll leave that slide on for you to review. This essentially just captures the key things we need to be thinking about when looking at introduction of new products within a country context. I'll stress just the inclusion of women's voices across the value chain, looking at the funding available, ensuring that key stakeholders are engaged, and that you have a clear pathway to introduction and scale up, which is going to look different across different countries. So with that, I think I can leave you with those final thoughts on the screen.
Wanjiko, thank you very much for a very informative presentation and highlighting some critical components about the introducing new methods and considerations for advocacy. The inclusion of women, very critical, and also taking care of the scale-up needs, whether it's policy or financing or system implications. So we have about 8 minutes before we finish the session, and we now have entered a time of questions, and I noticed that we already have some that have come through, and I'll begin first with just an observation that was made by one of the participants, that perhaps the non-use of the female condom is linked to poor awareness on the part of health professionals. And then continuing, let me address, this is a question to you, Clancy, and it comes from Samuya Ramarao, who says that you have laid out very well the tension between achieving equity and increasing CPR and the trade-offs. And that given this tension, what specific efforts are required to incentivize private sector to participate when the market may be small. Socially inclined manufacturers may not always be available. So Clancy, over to you, please.
Yes, thank you for the questions. I mean, I think this is a very interesting and challenging question, and I wish the first presenter was here as well, because I think he would also have some interesting insights. In general, I think with private sector partners, if we are interested in getting the commercial sector to engage, they will need a profit motive. So look first at the profit motive. In countries where you have a market size that is large enough, or you can make a justification based on a large enough market size regionally, the market sizes can be very useful for engaging private sector manufacturers and distributors, because it makes a business case for them. To get a profit margin that the profits that they want, they would have to have a large market size with a smaller profit margin, or a larger profit margin with a smaller market size. So those are the two factors going into their overall profits, is the size of the market. And I may be simplifying this a little bit, but you're really looking at the size of the market times the profit margin on each product. And then you'll get the overall profits. So if the market size is quite small, there is less motive for the private sector. However, if it's priced high, they will then have a bigger margin on each product. Unfortunately, for equity reasons, we often can't price the products high. We need them to be affordable for the consumers. So then we are left with options and related to private sector partnerships that incentivize engagement. One way to incentivize engagement through a private sector partnership is to increase the market size through demand creation. So specifically, we have USAID in the past had an engagement with Bayer Pharmaceuticals for an oral contraceptive, where we paid marketing and demand creation costs to increase their market for an oral contraceptive in sub-Saharan Africa. And that market was built, the product is still available. So by paying marketing and demand creation costs to increase the size of the market, we can incentivize commercial engagement. We can also engage in other private sector partnerships that might either increase the volume that they can sell, or that would perhaps subsidize the prices to an extent that it is more attractive to the private sector. When we do the subsidies, of course, we have to think about the long-term sustainability of those subsidies and how we would wean off them. So I think there's a lot of challenges with it. We need to think about how we can increase their market size, how we can build the market for them, and how we can also look at what are the best prices with willingness to pay data that helps them to understand where they can price the product so that they can have a decent margin and then a profit motive to engage.
Thank you very much, Clancy. We have a question from Paul Hassan that don't we think that strengthening primary health care would increase the uptake of the family planning methods in the community? Yes, certainly, with the right investments in place, so that it would mean that there's a system that avails information to households, and there is a system that has referral systems back to the clinics. Perhaps there's some community-based distribution of some products, and there is a way that clients are able to access other methods. So it means that this is a health system change that would have to be put in place. And we know that in many countries, this has been seen to work. The next question, and perhaps we may only have time for one question, a quick one to Wanjiko, concerns inclusion. And there's a question from Paul Hassan that, don't you think that male spouses should be carried along in the choice of the products, as you were talking about inclusion? So over to you, Wanjiko.
Yes. I think when we were looking at inclusion, we were looking across the full spectrum. And yes, we do agree that having male champions, male spouses does support new product introduction, particularly at community level. We have seen that. I think what we are missing really, as I had mentioned, is particularly when we're looking across the value chain of research and development, that underrepresentation of women in leadership, levels, or where they're actually making decisions about the research priorities, the needs of the communities, and issues around how products can be introduced and scaled up, tend to be very skewed. And when I say skewed, not just skewed towards male perspectives, but then also skewed towards higher income countries. So being able to correct for that requires the voices and the perspectives of everybody across the value chain.
Thank you very much, Wanjiko. And at this point, I want to bring our learning session today to a close and to thank Clancy and Wanjiko and Olawale very much for your contributions today. A lot has been shared this afternoon, a lot of considerations from the point of view of looking at the research and development processes and how that even starts, so that there's a conversation about getting products. Is it responsive to the country needs? The fact that there are a few players who are financing research, and how do you get country buy-in? The reality that introducing a new product requires so many systemic changes, and that it needs very many players involved. And as was shared by Wanjiko, and then from Olawale, looking at the health system from financing, the perspectives to the approach in the market, private sector versus public sector. So we have definitely learned a lot today. The reality is that there is need to continue on this road of availing products, because these products are intended to answer a question that is raised by the users and to meet a gap. And I think what we are saying is that gap needs to come from the consumers themselves. So we will continue to learn more from one another. And now, with regard to the presentations that we've had this afternoon, we will have links shared so that you can access the presentations. I know that there were questions about what about the French speakers, that there will be, these presentations will be made available to you. So thank you very, very much. And thank you too for all the comments that you have made. I know that Olawale did answer some on the chat. Thank you for being with us, and we look forward to continuing to learn together as global partners. So goodbye, everybody. Good morning, good afternoon, and good evening. Bye.